The speaker for this presentation is Anitha Vijayan.
Good morning, everyone, and thank you for having me today. My topic that I'll be discussing for the next 15 minutes or so will be the dialysis applications recommendations from the ADKI meeting on COVID-19 associated acute kidney injury. So I just wanted to start out with a case that we had. This is our first patient with acute kidney injury from COVID-19 that we took care of at our institution. So this was a 51-year-old gentleman who came in with acute kidney injury. He already had stage 3 CKD. He presented with syncope, and he also had fatigue, cough, fevers, chills, and diarrhea. His admission serum creatinine was 7.1, and patient deteriorated rapidly in the hospital after admission, and in 3 days, an ACT or an acute care event code was called, and he was intubated and transferred to the ICU. And this is what his chest X-ray looked like at that time. So as you can see, bilateral pulmonary infiltrates. It's very hard to tell if this is pneumonia or simply pulmonary edema. He was severely acidotic with a pH of 7.14. So as we all know, in these scenarios, it was very difficult to decide when this was all due to fluid overload, or if this was all due to pneumonia and the patient may have some underlying volume depletion. So we had to do a balancing act between aggressive diuresis and aggressive fluid resuscitation. And once all the non-dialytic treatments options that were just discussed were completed, then we had to look at renal replacement therapy. And as with any other patient, we had to discuss timing, dose, and modality of renal replacement therapy. So this was discussed at length during our ADKI meeting, and so I will go over our recommendations. So as you know, during the COVID-19 pandemic, the START AKI trial was also published. This was published in July of this year, and this compared a standard, what they call the standard arm, which is the criteria seen here: hyperkalemia with potassium greater than 6, pH less than 7.2, bicarbonate less than 12, PaA2, FiO2 ratio of less than 200 plus volume overload, or persistent AKI for 72 hours after randomization. And this was compared to the accelerated group. And as you know, there is no difference in outcomes with regards to mortality. And so this is the criteria that most of us would probably use for starting patients with COVID-19 or otherwise on renal replacement therapy. So what we did for our recommendations for COVID-19 patients was generally follow the standard arm of START AKI, but of course, there are other factors to consider as well, and including practical points like personnel to place catheters and also personnel to start renal replacement therapy. These also affect timing. And also we have to keep in mind that there was no subgroup analysis of oliguric or anuric patients. So if your patients are very oliguric and anuric, they may need earlier initiation. So from our recommendations, we suggested that consider acute renal replacement therapy when metabolic and fluid demands exceed total kidney capacity, and consider broader clinical context and conditions that can be modified by RRT rather than BUN or creatinine alone when determining the need for RRT initiation, meaning that we shouldn't strictly go by the KDIGO AKI criteria. So during the pandemic, we had an acute need we had a surge of patients coming into our hospitals, and surge was a major concern. So we also recommended that the non-dialytic options should be used first before initiating renal replacement therapy for various reasons. We had shortage of PPE, we had shortage of equipment, we had shortage of dialysis fluids, and so any non-dialytic options should be considered before starting renal replacement therapy. And of course, the RRT should be initiated immediately if there's a failure of conservative measures or clinical deterioration. What about modality? So selection of modality should be based on patient needs, local expertise, and availability of staff and equipment. A lot of centers had to switch to different modalities as the resources became low, and I'll touch base on that in the next few slides. And we also suggested that CVHD or CVHDF modalities may help with clotting. As you know, clotting was a major issue with patients with COVID-19, and CVHD or CVHDF helps to reduce filtration fraction, and this may help decrease clotting of filters. So these are the 4 CRT machines currently available in the United States. There's the PrismaFlex, there is the Next Stage System 1, there's the Prismax, and there's the Tablo. So each of these can provide different modalities of CRT. Tablo can only provide CVHD. The Next Stage can provide either CVH or CVHD, and the PrismaFlex and Prismax can offer CVH, CVHD, or CVHDF. But there's no need to buy a different kind of machine from what is used at your center. However, we do recommend that each institution analyze their supply and their capacity and decide if they need to buy more machines. What about PERT? So prolonged intermittent renal replacement therapy can be provided by using one of the CRT machines, either the Next Stage System 1 or Tablo. Actually, Prismax can also be used for PERT as well, since it also has an effluent line. Some centers continue to use dialysis machines like the Fresenius machine here. This picture is courtesy of Dr. Juan Carlos Vélez from Oxnard. And any of these machines can be used to provide prolonged intermittent renal replacement therapy. So what's the advantage of PERT? So it can be performed, as I said, either with intermittent hemodialysis or CRT machine. Most centers, you do not require one-on-one hemodialysis nursing to do PERT, and the dose calculation is fairly simple. If you look at the effluent flow rate of CRT of 20 mils per kg per hour, you can take the total amount of fluid required for 24 hours and divide that by number of hours on treatment. Usual duration is 10 hours, but if you allow for a cleaning and downtime about 1 to 2 hours, you can use the same CRT machine for 2 patients. If you use a duration of 6 hours, you can use the machine for 3 patients even. Of course, the flow rates will have to be higher depending on the number of hours that you're using. SLED prescription, this is when you would use your hemodialysis machine. As I said, in the United States, the most common machine that is used for SLED is the Fresenius 2008. The blood flow is usually turned down to 200 ml per minute, dialysate flow about 100 to 200 ml per minute, and the usual duration is 8 to 10 hours. So during the pandemic, modality choice was affected by the supply of disposable materials, including tubing sets, also dialysis solutions, and need for anticoagulation. PERT and hemodialysis offer advantages because you can provide RRT with reduced need for anticoagulation and shorter duration of therapy. And if hemodialysis or CRT machines were not available, acute PD was used in several centers in the United States for treatment of AKI in adult patients, and this was extremely unusual. So these are pictures from Mount Sinai and Montefiore in New York, where surgeons were posting pictures of how they were putting in catheters in interventional radiology suites or at bedside. And as you can see, the cyclers here lined up to do acute PD. What about dosing of renal replacement therapy? So The recommended dosing from KDIGO is a urea reduction ratio of 65 to 70%, which translates to a single pull KTOV urea of 1.2 to 1.3 3 times a week for intermittent hemodialysis. For CRRT, the recommended effluent flow rate is 20 to 25 mils per kg per hour. Anything above that, we know that it doesn't really offer any survival benefit, and below that, we're not sure where the floor lies, right? So we don't know if there's what is a lower amount that might be safely used. We of course know that 0 is bad. So during the pandemic, just for COVID-19 patients who had acute kidney injury, our recommendations were similar: effluent flow rate of 20 to 25 mils per kg per hour, and intermittent hemodialysis 3 times a week. PERT, you have to be careful when you provide it 3 times a week because the dosing may not be adequate. PERT is usually provided maybe 4 to 5 days a week, depending on the dose of dialysis or urea reduction. And interruption of prolonged renal replacement therapies due to circuit clotting or other reasons can have a substantial impact on the delivered dose and may impair patient outcomes. So considerations for intermittent hemodialysis in acute kidney injury: not every patient needs a 4-hour intermittent hemodialysis. So if your center normally does not track urea kinetics, sometimes every patient might be getting a 4-hour treatment, which they may not need. Consider the shortest duration that achieves metabolic control. Remember, the nurses have to be sitting in the room with the patient with a full PPE to provide this dialysis treatment for the patient, and the nurses are at higher risk for getting the infection. So we want to minimize that 1-to-1 treatment time in the room, RN time in the room. So what about CRT? So we made a recommendation that in order to conserve fluid, consider using lower than usual flow rates once metabolic control has been achieved. So if you're usually dosing 20 to 25 mils per kg per hour, maybe you can bring that down to 15 to 20 mils per kg per hour as long as a metabolic control is achieved. What about vascular access? So right IJ is the preferred site for dialysis catheters. Now, remember that prone position, obesity, and hypercoagulability may affect vascular access performance, and we need to pay attention to catheter placement and appropriate catheter length. So usually hemodialysis catheters are placed by nephrologists and intensivists who are familiar with the different lengths that are required. However, during the pandemic, other physicians were in the ICU to provide assistance. And we found that providing a cheat sheet to share with everyone regarding catheter lengths was extremely important. So right IJ, the preferred catheter length is 15 to 20 centimeters, depends on the height of the patient. Femoral is the next preferred, although there's some controversy between femoral and left IJ. The femoral length is 24 to 30 centimeters. Left IJ, the length is 20 centimeters. And for the last resort, a subclavian vein can be used, and the catheter length is around 20 centimeters. So what are the advantages and disadvantages of various modalities in acute kidney injury? So intermittent hemodialysis is widely available. The main limitation is nursing, and it allows treatment of several patients with the same machine in a given day. And again, the main disadvantages is that the nurse has to sit in the room with the patient for an extended period of time to provide this dialysis. Now, COVID-19 patients are frequently hemodynamically unstable in the ICU, and so intermittent hemodialysis may not be the best modality for those patients. What about PERT, whether you provide it with a hemodialysis machine or a CRT machine? Again, it's probably equivalent to a CRT as far as use in hemodynamic unstable patients. The biggest advantage is that it allows the use of a single CRT machine for up to 3 patients per day, depending on how good you're at turning over the equipment. And there's also, for PERT, you can have a higher blood flow compared to CRT, and this may reduce the risk for filter clotting. Again, if your institution was not familiar with PERT before, this was something that you had to rapidly implement, and you had to track the multiple machines that we were using in different patients to make sure they're all cleaned appropriately and used for the next patient. So there were some challenges in logistics, and there's also some challenges with regards to drug dosing, especially antimicrobial agents. What about CRT? Ideally, this should be used for majority of the patients in the ICU. It's easiest to use, but however, clotting was a big issue. And also when your resources were running low, remember CRT will require 1 machine to 1 patient per day. So this really was a disadvantage in COVID-19 because institutions ended up having to buy more machines to keep up with their demand. Peritoneal dialysis. Across the world, PD is available in resource-poor countries, but usually has not been widely used in adults with acute kidney injury in US and Europe. So there is a huge learning curve in how to do PD, especially with regards to placing PD catheters in the acute setting. And also protocols and policies for acute PD were not available at all sites, and these had to be created and implemented very rapidly. Also, PD was extremely challenging in patients who were on high vent settings and those who were prone. So these were some of the disadvantages of using PD in COVID-19 patients. What about hypercoagulability? As you know, this was a major issue in our COVID-19 patients. If there's one thing that definitely set the COVID-19 patients apart from other patients with sepsis, it was hypercoagulability. And this was a review of studies that showed high rates of DVT and other hypercoagulable states like PE in various countries. So what are our recommendations? So we recommend that patients with COVID-19 receive anticoagulation during RRT. And we also recommend that circuit performance during RRT be closely monitored to ensure maximal circuit patency. Remember, we were trying to save filters as much as we can and prevent blood loss. Now, what anticoagulation should you use? This is an example of what we recommended here. So systemic heparin was recommended here with a PTT of 60 to 90 seconds. Now, if you are a center that's normally using citrate, you can start out with citrate. If one doesn't work, or if a patient develops bleeding with heparin or HIT positive, you can switch them over to citrate. Or if citrate is not working, you can try heparin alone or use the combination. If you're unable to maintain filter patency, you may have to work with your hematologist and pharmacist to consider other options. We also cautioned against implementing citrate protocols in a hasty way during the pandemic, since side effects or systemic effects of citrate can be extremely lethal if not done correctly. So during the pandemic in the United States, there was a shortage of dialysis and dialysis equipment. This was an article in the New York Times that described the course of a patient with hyperkalemia who, according to the family, could not get dialysis in a timely manner, and eventually he passed away before PD was finally implemented. So even though we had government had resources for providing ventilators, there was no dialysis machines that were available immediately, and so there was definitely a shortage of dialysis machines. And also, this was a this was a tweet from a doctor in New York about dialysis being like an auction. You know, if somebody's case 6.7 versus 6, they were more likely to get the dialysis treatment that day. So for future, the ADKey group recommended that we plan ahead. So make sure the nephrologist has a seat at the table. Make sure we assess our resources at our individual institutions and lead local and regional responses, or be involved in the local and regional responses, have a plan in place for surge. And this could be in the setting of the next pandemic, or it could be a natural disaster. It could be a water main break at your institution. It could be any of those scenarios. So we need to have a plan in place to prevent, or I should say, to lead the way for ensuring that RRT is provided to every patient who needs it during the next crisis. So thank you, everyone. In my summary slide, I just wanted to emphasize all the points that I made in choosing the modality, dose, and vascular access for patients with COVID-19. Thank you.